Hi, today's topic is unexpected stillbirth. It's a really strange but true that the most important turning point of life often come at the most unexpected times, and it is most unexpected ways. Unexpected childbirth, stillbirth is also like that. It is a devastating reality, and that can happen to any family and can take a serious toll on the families and their communities. Stillbirth is one of the most devastating life events, substantial physical, psychosocial impacts on women, families, and society. It's a huge public health concern. In 2019, globally estimated 1.9 million babies were stillborn. India topped the wrong charts with maximum numbers of stillbirth. The irony is that stillbirth have been absent from most of the programs so far. They are invisible due to social taboos, stigma, isolation, etc. With stillbirth, we have seen, because it's the most devastating condition, every unborn baby has right to receive the best care. As we talk about the respectful maternity care, same with every unborn baby has right to receive the best care. All bereaved parents must have the highest quality of respectful bereavement care. The temptation to quit will be greatest just before you are about to succeed. And the preventing a stillbirth is lifetime of love and livelihood for a family. Now, how to count every stillbirth is very, very important. Improve the quality of care during pregnancy and childbirth. There should be more and more awareness in general public as well as in our own domain for the stillbirths, and we should provide bereavement care to the all parents who are having the stillborn child. So these are the four things, but the big issues are there's a claimant, a 38-year-old, suffered a stillbirth while under the care of defendant's trust. She claimed that it was a negligent in falling to recognize the baby was not growing normally and in falling to carry out the growth scan in spite of hospital attendance for reduced fetal moments. It had been performed, it would have been identified that there is a reduced liquor and baby was small and delivery expedited earlier, preventing the stillbirth. She claimed for the damages on the grounds of suffering, psychiatric injury, and also suffered a loss of self-confidence as she is unable to return to work. So this is a big problem, and any person can sue the gynecologist for the stillbirth. A stillbirth is defined as a delivery of a baby who shows no sign of life or breathing after 20 weeks of gestation or within a birth weight of 350 grams or more. Unexpected stillbirth occurs in 0.5 per 1,000 births over 24 weeks of gestation. Most of have identifiable obstetric or perinatal antecedents. Delivery of the fetus showing no signs of life, absence of breathing, absence of heartbeat, absence of umbilical cord is there is no palpable no pulsations, and definitely voluntary movements are there. It excludes the transient cardiac contraction and fleeting respiratory efforts is sometimes the gasp is excluded. Now the definition is like no, not all the fetal deaths are stillbirths. The World Health Organization, WHO, the fetal death late in pregnancy allows each country to define the gestational age at which the fetal death is considered stillbirth. So the main problem with the definition all over the world, there is a different issues at what gestational age of the fetal death should be considered stillbirth. It can be 16 to 28 weeks. National Center for the Health Statistics, the most states use 20 weeks or the fetal weight is more than 350 grams or more than 500 grams or 20 weeks late stillbirth. So early stillbirth is between the 16 to 28 weeks and after the 28 weeks is a late stillbirth. This is a Tennessee code annotated that the fetal death more than 500 grams weight or in the absence of weight, it should be the more than 22 weeks. So those two things. So everywhere, the National Health Center, the Tennessee Code, and the World Health Organization, the definitions are different from the state, country, and with the gestational age and the weight of the baby. So important point is, what is the incidence of this? More than 3 million stillbirths each year worldwide, 6.2 per 1,000 total births. Rate of early stillbirth has remained stable. Rate of late fetal loss has decreased by 29%. And another important point is, this African American have double chances of stillbirth rate as Caucasians. Now, what are the causes? What is the etiology? Why it happens? And the most of the cases, the cause is not known. 25 to 60% of the cases, the cause is not known and really difficult to explain why stillbirth happened. And that's more troublesome for the gynecologist, for the patient, for everyone. The identifiable causes can be attributed to sometimes the maternal conditions. She can have anything like right from trauma, infections, tumors, anything can lead to stillbirth. Then the fetal conditions, if the baby is having the congenital anomalies, any X-linked diseases, or any abnormality, they can also end up into stillbirth. Placental conditions are another importance of the accreta, porcreta, or any placental problems are there. There are the chances. Now, the maternal conditions which are important for the causes, they are prolonged pregnancy. There can be poorly controlled diabetes. There can be a systemic lupus erythematosus. Then there can be APAS, infection, hypertension, preeclampsia, eclampsia, hemoglobinopathies, AMA, RH disease, uterine rupture, maternal trauma, or death. And sometimes inherited thrombophilia is another important cause. Now, the fetal conditions, a baby, there can be a multiple gestation, severe intrauterine growth retardation, any congenital anomaly, genetic abnormality, infection, hydrops are the reasons of the fetal condition for the stillbirth. Placental conditions, again, there can be a sudden abruption of the placenta, can be cord accidents, premature rupture of membrane, vasa previa, feto-maternal hemorrhage, and placental insufficiency. The most frequent types of the stillbirth according to gestational age, 24 to 27 weeks, 28 to 37 weeks, and 37 plus weeks. The chances of infection is 19%, unexplained 26%, and unexplained 40%. So the chances which are unexplained are there in more into 37 plus weeks. But if there is an infection, the chances is 19% between the 24 and 27 weeks. Abruptio placentae, 14% between 24 and 27 weeks. Fetal malnutrition, 19% in 22 to 37 weeks. Again, fetal malnutrition, severe IUGR can lead to stillbirth in these type of patients. Anomalies, the more the anomalies are there, chances of stillbirth earlier weeks, like 24 to 27 weeks, and a late chances are abruptio placentae and problems into the placenta. So whenever there is an infection, anomaly, and abruptio placenta, because of any reason, the 24 to 27 weeks, the chances are there, but the late weeks pregnancy, there is more of the malnutrition and placental things. Now, which type of infection can cause stillbirth? The most common stillbirth is 24 to 27 weeks. Contribution to stillbirth rate is difficult to define. Some pathogens are clearly causing related, parvo B19, CMV virus, toxoplasmosis, and some are associated with stillbirth, but absent evidence of causal relationship. So, urea plasma, urea lyticum, this is one of the things. They are found, but there is no evidence like that. Same with Mycoplasma hominis and GBS. GBS is an infection, but not relevant and relationship. And colonization of common along the health women. So they are there, but we cannot say that they are responsible for the stillbirth because their evidences are not that important. Now, most stillbirth occur in the premature fetuses. 19% of the stillbirth is less than 28 weeks if there is any infection. 2% stillbirth at term. No change despite widespread use of antibiotics. Viral pathogens are most common source of hematogenous infection of the placenta. Fetal death resulting from the maternal infection is rare, and diagnostic criteria are not well defined. So this is the main problem, that we can say that because of this infection, that has gone through maternal infection and that is causing the stillbirth. It's not rightly definable, and high frequency of asymptomatic maternal colonization. So there may be lot much colonization of any bacteria or any infection is there, but still if the baby is well, then nothing can be done, but sometimes it cannot be correlated. Now the multiple gestation, 19.6 out of 1,000 stillbirth rate, it's a 4 times more than the singletons. Complications specific to the multiple gestation is TTTS, transfusion syndrome, and increased risk of common complications. There are advanced maternal age, fetal anomalies are more, and growth restrictions because of the multiple gestation is one of the reasons. Now, advanced maternal age is a lethal congenital and chromosomal anomaly. Medical complication associated with age, multiple gestations, hypertension, diabetes mellitus. AMA is an independent risk factor. Unexplained fetal demise is only type that is statistically more common in late pregnancy. Now, advanced maternal age, risk is more behavioral, socioeconomic and obstetric factors, smoking, diabetes, preeclampsia. Risk remains even after controlling for above theories. Perception of the fetal movements is another important point. Hyperlipidemia and apnea, hypoxia events. Obesity. This is the BMI and stillbirth rate. More than 30, 5.5. More than 30 to 39, it's 8. And it's a grossly, greatly obese females more than 40. The chances is 11 per 1,000. This the chromosomal abnormalities. That's an abnormal karyotype found in 18 to 13% of stillbirths. More than 20% is anatomic abnormalities or the growth restrictions. 4.6% with normally formed fetuses. Most common abnormalities, monosomy X 23%, trisomy 21, that is 23%, trisomy 18, that is 21%, and trisomy 13, that is 8%. Karyotypic analysis is underestimated the risks. Again, what is the obesity and success rate? Amniocentesis, 85% success rate. Fetal tissue sampling, 28% can be. Now the fetal tissues. They're so important. How that tissues have been responded with a stillbirth baby, we should know. And we should find it out in a postmortem to find out that these patients are having the stillbirth and what is the chances of the tissue involvement into this. Umbilical cord, 32.1%. Fascia lata, 20.9%. Cartilage, 24.2%. Fetal blood, 22.2%. And pericardium, 0%. Other tissues, 19.2%. Placenta, skin, and unknown. These are the tissues. Now, the cord accidents, 30% of the normal pregnancy, account only for 2.5% of the stillbirth in autopsy cases series, and attribution requires cord occlusion and hypoxic tissue at autopsy. And we should also exclude the other causes. Actual proportion remains uncertain. Thrombophilia, there is a relationship of the late fetal death is more consistent than the early losses. It has been associated that the late loss but lack of evidence is a causal relationship. Inconsistent studies, OR range from 1.8 to 12, and thrombophilias are not uncommon. 15 to 25% of the Caucasian population can have the thrombophilias. Thrombophilia, some but not all the studies show the relationship with the adverse outcome. Most are retrospective, case controlled. Prospective longitudinal studies are needed. Inappropriate, no control, no evaluation of other causes. At least one type of thrombophilia is seen in 30% of normal controls. Now, how to evaluate? When the stillbirth is there, we are supposed to evaluate what is the cause, why it happened, and what we should do in the next pregnancies. And that's very important. First and foremost is a fetal autopsy. Single most useful test. Examination of placenta, cord, and membranes. Then second is a karyotype evaluation of the stillbirth. And the 18 to 13% of the stillbirths, there are chances of karyotypic evaluation should be done, and they have found it's a genomic hybridization, useful when fetal cells cannot be cultured. Infection, in autopsy and histological evaluation of placenta, membranes, cord provide best evidence of the infectious etiology and value of routine culture and serology, though it's controversial. Previous serology screening for syphilis, torch titers, questionable utility. So should be done or not to be done, it's a questionable. Placental culture is another problematic thing. So it's not be able to sometimes be done. The incidence of live birth is also unknown. So if we have done the placental culture into the live birth babies and it should be compared with the stillbirth babies, so that's a really problematic because the incidence is almost not possible to say that this is the only reason for the stillbirth. So DNA test associated, the chances of false positive are more and more. Now, these are the medical complications which we see when there are the stillbirth. Exclude clinically over diabetes and thyroid dysfunction. GDM has stillbirth rate similar to normal. Subclinical thyroid disease has not been proven as a cause of stillbirth. Screening of subclinical disease is unproven benefit. So what we are supposed to do if the months the mother is already being having a stillbirth, now next pregnancy when she comes to us, what is our importance of doing the antepartum surveillance? A little evidence-based data to guide testing with the previous unexplained stillbirth. Still, at the 32 to 34 weeks, we're supposed to deliver the baby. 2 to 4 weeks before the gestational of the previous stillbirth, that should be the idea of delivering the baby. Increased risk of iatrogenic prematurity is there, but this is the one of the way of saving the babies is another important point. But the most subsequent pregnancy have a favorable outcome. So that is a positive point and a good green flag over there that the once the stillbirth, the next pregnancy, the chances of favorable outcome are more and more there. Another important point, the 300 women with the previous stillbirth, 49 unexplained, one recurrent stillbirth despite the reassuring testing. Perinatal mortality 3.3 out of 1,000. Earliest delivery associated with the positive test result was 32 weeks. Now, what should be the protocol? The protocol may not be appropriate for all previous stillbirths. It's a non-recurring conditions. Maternal trauma, stillbirth following the obstetric complication that can recur but cannot be predicted. Chances of abruption, prolapse, and uterine rupture is there. The non-recurring conditions like a perinatal infection, fetal anomaly, and maternal trauma are important. Now, out of all this stillbirth discussion, the medico-legal issues are very important. Parents should be advised for the postpartum examination, provide more information than other less invasive tests, and this can sometimes be crucial to the management of future pregnancy. Attempts to persuade parents to choose postpartum must be avoided depending upon the individual, cultural, religious belief, and that should be respected. Written consent must be obtained for any invasive procedure on the baby, including tissues taken for the genetic analysis. Consent should be taught directly, supervised by the obstetrician or midwife trained in special consent issues and the nature of perinatal postpartum, including retention of any tissues for clinical investigations, research, and training. Parents should be offered a description of what happens during the procedure and likely appearance of the baby afterwards. This should include the information on how the baby is treated with dignity and any arrangements for the transport. Discussion should be supplemented by the offer of leaflet. Postmortem examination must include the external examination with birth weight, histology of relevant tissues, and skeletal X-ray. Pathological examination of cord, membranes, placenta should be recommended whether or not the postmortem examination of the baby is requested. The examination should be undertaken by specialist, that's perinatal pathologist. Parents who decline full postpartum might be offered a limited examinations, sparing a certain organs, but this is not a straightforward and should be discussed with a perinatal pathologist before being offered. Less invasive methods such as needle biopsies can be offered, but these are much less informative and reliable than convenient postmortem. Ultrasound, magnetic resonance, MRI should not yet be offered to the substitute for the conventional postmortem, but MRI can be useful adjunct to the congenital postmortem. Now, to conclude on the stillbirths, barriers crossing will need awareness, health education, demand creation into the community, socio-economic upliftment of the population, physical as well as communication infrastructure should be good. Development on one hand and the manpower development, their effective deployment of the health sector on the other. Women's empowerment plays an important role in reducing stillbirth. Stillbirth rate is an important indicator for the quality and the care of pregnancy and childbirth. It's a sensitive marker of the health system strength and measuring not only the process of achieving SDG target or reduction of neonatal, maternal, and under the 5 mortality, but also progress the other targets aimed at reducing poverty, increasing equity, and access to the healthcare. Extra and directed efforts will be necessary in overcoming the barriers at service community interfaces in achieving our goals. Thank you so much for patient listening. Thank you so much. Thank you so much.